Okay, so good morning, everyone. My name is Karla Hernandez Mendiola. I'm an international medical graduate from Mexico City. And so today I will be talking a little bit about migraines. I decided to talk about this because it was the main chief complaint during my rotation. So I thought it was a great opportunity to review this topic. It's not changing. How do you change it? So some of the points I'll be reviewing is epidemiology, diagnosis, the pathogenesis of migraines, genetic features, treatment, early and preventive, migraine in children, and my conclusion. So just a brief introduction. Migraines are one of the most oldest disorders that we are aware of. Some of the earliest cases of painful headache were recorded by the ancient Egyptians, and the word migraine comes from the Latin word hemicrania, which means half of the skull, and which is used to describe the pain felt across one side of the head. And usually, this is how patients come to the clinic and describe their headache. In the papyrus, we are able to find that they will wrap a crocodile around the head as a remedy for the migraine. I'm not sure how would that help, but yes. Epidemiology. So migraines affect approximately 1 billion people worldwide, according to the Global Burden of Disease study, which I think the last one was in 2017. Migraine is the second leading cause of disability. This comes after tension type headache and is more predominant on females with a prevalence of 15%. And the prevalence peaks between the age of 35 and 39 years old. This is most likely related to hormonal changes, work overload, and other personal things that could be happening through that age. But around 75% of patients will have reported the onset of a migraine before age 35. And it's also really important to mention that migraines tend to remit with older age. And so an onset of a migraine or headache after the age of 50 should make us suspect of a secondary headache disorder. Last but not least, the prevalence in children, it's around 7% in school age children. 7% sounds like a low number, but it's really common. I've seen a lot of children with migraines during this age through medical school and also here in the clinic. Diagnosis. So the diagnosis is based on clinical criteria provided by the International Classification of Headache Disorder. And it will provide criteria for three of the main uh, categories of migraine, which are migraine without aura, migraine with aura, and chronic migraines. Uh, we will also include a complete physical exam in which most of the times will be normal. And we will also do our differential diagnosis of migraine, which include primary headache disorders and secondary headache disorders. In our primary headache disorders, we have a tension type headache and a thunderclap headache, and secondary post-traumatic headache, brain tumors, or infection. We always have to be aware of red flags on physical exam that will require our consideration of diagnosis other than a migraine. This could be fever, neck stiffness, and weight loss. So this is the table with the criteria given by the ACHD3. And so So I'm gonna review each criteria. So for migraine without aura, at least 5 attacks have that meet the following 4 criteria. Criteria number 1, it's time. The headache has to last between 4 to 72 hours, and these have to be untreated or unsuccessfully treated. Criteria number 2 are the correct characteristics of the headache, which have to meet 2 of the 4 of the list. Unilateral location, pulsative quality, moderate or severe in intensity, and aggravation with physical activity. Third criteria, associated symptoms, which have to be 1 of the 2, which is nausea or vomit, and photophobia or phonophobia. And for 4th criteria, we have that it has to be not accounted to another diagnosis. The criteria for migraine with aura, these have to be two attacks with 3 criteria. First criteria, 1 or more of the reversible aura symptoms. These aura symptoms can be visual, which are referred by patients as scintillation and scotomas. Sensory, which is referred as numbness, tingling, or pins and needles sensation. Speech aura can be referred as slowed speaking or alteration of the precision of articulation. For motor auras, we have weakness, and for retinal aura, a partial or total loss of vision. Second criteria, how the aura presents, and these have to meet at least 3 of the 6 in the list. First one is 1 aura symptom spreading gradually over a period of 5 minutes. More than 2 of the aura symptoms occurring in succession. Each aura symptom lasting 5 to 60 minutes. 1 unilateral aura symptom, 1 positive aura symptom, or a headache following an aura within 60 minutes. This also have to be not accounted to another diagnosis. And for chronic migraines, this can be diagnosed with 1 of the 2 criteria. First criteria, a headache has to be for more than 15 days per month for 3 months, and meet also the criteria for 1 of the migraines with aura or without aura. And the second criteria that can be used to diagnose is features of migraine for more than 8 days per month for more than 3 months, and relief by triptans and agar derivatives. So it's worth to review all these criteria just to make sure we're making the right diagnosis. And here some images of how they will describe their scintillations, which are bright flashlights, or the flashlights are referred as different colors, like rainbow-like. Physiology of the aura phase. So how the physiology of the aura phase is explained. This is thought to be a cortical spreading of depolarization across the cerebral cortex, disrupting ionic gradients, and then followed by a cerebral hyperperfusion. Hemodynamic changes have been documented on neuroimaging in patients who have migraine with aura, and those changes are not present in patients who don't have aura. Here I put some images. So this is a case of a patient with a really severe migraine. So I'm gonna just read what's the case about. This is a 37-year-old man with an acute onset left homonymous hemianopsia, numbness in the right arm and face, and throbbing right-sided frontal headache, followed 30 minutes after his neurological deficit. At the time of his presentation to the ER, he had severe headache and nausea. His vital signs and the results of his routine biochemistry and CBC workup were normal, Findings of his physical and neurological examinations were within normal limits, except for a left homonymous hemianopsia. He was admitted to the neurology department with the initial diagnosis of migraine with aura. To rule out a stroke, MRA imaging was done. So the 1A image shows an MRA where you can see diminishing of the distal branches of the right middle cerebral artery. The 1B image, there's a mild delay in the mean transit time and mild decrease in the cerebral blood flow and volume in the brain parenchyma of the right parietal occipital lobe. And the third image above shows a prominence of the venous vasculature in the same region of the right parietal occipital lobe. So the patient headache and neurological deficit resolved completely after 10 hours. And 2 days after the migraine attack, the perfusion MR and the MRA the findings were totally normal. And we can compare. It's really obvious the difference between before and after. And well, really the physiopathology is not really known and established, but the most likely explanation for that is an activation of the trigeminal vascular system through cortical depression. But there's still other hypotheses. So for the triggers, patients will often describe different types of triggers. However, retrospective assessments are limited by some recall bias and false attribution. And this is supported by a study that was done to induce migraine attacks by exposing patients who had a history of migraine with aura, and they were asked to self-perceive the triggers. And only 3 of 27 patients had migraine attacks, which suggested that it was most likely a belief of each patient. And so the role of these triggers is really limited. This is just a small list of most of the most common triggers that you will hear of. And so what's the physiology of the migraine? So the trigeminal vascular system is considered to be the place where the transmission originates and yields to the perception of migraine pain. First thing that has to happen is an activation of a first order trigeminal vascular neuron, where the afferent fibers of the trigeminal ganglion innervates the meninges and its vessels. From there, the transmission is projected to the brainstem, where it will activate second order trigeminal vascular neurons. And this in turn will activate a third order neuron in the thalamus, and which subsequently will transmit the signal to the somatosensory cortex, resulting in the perception of a migraine pain. Now, activation of the trigeminal vascular system can also result in 2 signaling pathways. First, a parasympathetic outflow to the intracranial arteries that will lead to a dilation of these same arteries due to the release of signaling molecules such as the PACAP, which is pituitary adenyl cyclase activating peptide, and vasoactive intestinal polypeptide. The other pathway is a release of a vasoactive signaling molecules such as calcitonin gene-related peptide, which also contributes to the dilation of intracranial arteries. These 2 pathways are AMP and GMP cycle mediated, and this will result in a opening of the ATP-sensitive potassium channels. And so this hypothesis has been supported after they created an IV potassium ATP channel opener, which is called levochromolin. And so they were able to cause migraine attacks after infusing this medication. So to determine if the molecules I just mentioned had a role in the pathogenesis of migraine, they did a clinical study where they administered these molecules, including also nitric oxide and GTN, to patients with migraine, and also they infused them to healthy people who don't suffer of migraine. And they established that the migraine attacks would develop in those with history of migraines when exposed to these molecules. And the patients that didn't have any history of migraines didn't report any kind of headache. So we can see that with the IV infusion of the nitric oxide and the GTN, patients with history, the 80% of the patients had an attack. CGRP infusion, 50% had a migraine. PACAP 38 infusion, 58%. And those medications that inhibit phosphodiesterase, making to increase the GMP cycle and the AMP cycle, 80% of them had a migraine attack. So these numbers really support the pathways I just mentioned before. So what is really the mechanism? Well, it's really unclear, even though we already reviewed different pathways of how this could happen. Still some evidence favors a peripheral origin, where some other data suggests that it's more likely a central nervous system thing. Some genetic features, we can see that family history of migraine is really common, with a heritability estimated to be a 42%. A genome-wide meta-analysis, 38 susceptibility loci were identified for migraine. And also migraine risk variants were enriched in genes related to vascular and visceral smooth muscle. At the end, genetic studies have shown that the risk of migraine is polygenic, with one exception, which is familial hemiplegic migraine. This is a migraine that runs in family, and patients have an aura of unilateral body weakness prior to the headache. Also, based on the molecules I just mentioned previously, randomized clinical trials have shown that targeting nitric oxide signaling through non-selective inhibition of nitric oxide synthase was really promising as a treatment for migraines, as well as drugs targeting CGRP and its receptors. And these are used as preventive and as acute treatment. The management of migraine should ideally be initiated by PCP, with a referral to neurologists for cases that do not respond to treatment. The mainstay of treatment will include an initial and a preventive medication, with also non-pharmacological therapy. We can just use non-pharmacological therapy in those cases where we want to prevent, we want to avoid any kind of medication. An example could be a pregnant woman. And some of the non-pharmacological therapy that have shown some benefit are non-invasive neuromodulatory devices, biobehavioral therapies, and acupuncture. Non-pharmacological therapy that hasn't shown any evidence of benefit at all is physical therapy, chiropractic manipulation, or dietary approaches. And so this is a table that shows how they measure the efficacy of treatment for migraine attacks in adults in a controlled trial. So they are basically measuring the freedom from pain 2 hours after treatment and before the use of the rescue medication. The table A is our NSAIDs, B are triptans, and C are CGRP receptor antagonists, which we can recognize because they will always have GPANs on the end. And here we can see that, well, it's really evident that the triptan in the middle is the most efficient in attacking the pain, but it's subcutaneous and its use is very limited because it's really expensive and less available than oral triptans. So we will always go first with NSAIDs and oral triptans. To alleviate the pain of migraine, medications should be given early in the headache. The most common initial medication for these are NSAIDs. We would use acetylsalicylic acid, ibuprofen, and diclofenac, which have shown to have the best effectiveness. Triptans are considered the second line medication. So if you use a triptan and it doesn't work, you can still change to another triptan. You can do this if up to 3 migraine attacks, and if after your third change triptans continue not to work, you can use a combination of a triptan and an NSAID, which we would use naproxen. Most recently, the FDA approved some of the CGRP antagonists and 5-HT1F receptor agonists for acute migraines. But right now, the high cost and the low availability make their use really limited. The main goal of the preventive treatment is to decrease the frequency, the duration, and the severity of the migraine. And it's really important to mention this to our patients. Sometimes they will frustrate because they don't see the results they're expecting. And sometimes they will be taking these medication as an acute treatment, which will work. So preventive treatment is for those who have at least 2 migraines, two migraine days per month, and those whose daily activities are affected despite therapy. The most common medications are antihypertensive agents like beta blockers and candesartan, antidepressant agents like amitriptyline, anticonvulsants, topiramate and sodium valproate, and calcium channel blockers. And also we have the new monoclonal antibodies injectable therapies. And so I really like this table because it just summarizes everything I just said. The algorithm for clinical management of migraine. And just a quick review, NSAIDs should be considered first line. In those who NSAIDs do not provide any pain relief, you offer an oral triptan. If an oral triptan does not work, you should give another triptan. If it's still, there's no pain relief, you use combination therapy with naproxen. And as your very last source, you can give a dieten or a gepant. You can also give antiemetic agents for nausea and vomit. And you start preventive treatment in those who have at least 2 migraine days per month and are really affected despite the therapy. Something really important to mention is that the use of opioids and barbiturates in the treatment of migraine is contraindicated because of the adverse effects and the risk of dependency. The management of migraine in children can differ from the management in adults. Ibuprofen is considered to be the initial drug of choice. If ibuprofen is ineffective, you use an oral triptan. And at the end, you use a combination of the sumatriptan and naproxen. There is no evidence that supports the use of preventive medication. And also children may benefit from biobehavioral therapies, such as biofeedback, relaxation, and cognitive behavioral therapy. We should be aware of the risk of medication overuse headache, which is a condition of daily headache or increasing headache frequency resulting from regular overuse of medication for migraine. In patients who at least have 15 days of migraine per month. So the main treatment of this is withdraw all the medication that the patient is taking for the migraine and initiate preventive treatment. So what are my conclusions? Migraine is a brain state in which the trigeminal vascular system is genetically susceptible. And even though a lot of uncertainties still remain regarding the mechanism of migraines, there's a lot of mechanism-based therapies that have shown to be working. And I think it's excellent that biomarkers are being developed to predict which patients will have a response to each target therapy. Thank you.